Good afternoon from Miami Beach. This is Dr. John Bennett,
you?
from the studios of Neurosurgical TV. Today we have the pleasure of having Nathalie Ghumsi, a doctor from Cameroon, applying for a residency in neurosurgery. She's going to give a presentation on the thalamus, and let's introduce a couple of guests. First, Dr. Kabulo, could you please introduce yourself?
Thank you, Dr. Bennett. My name is Kabulo. I'm from Democratic Republic of Congo. Currently, I'm final year neurosurgery at University of Zimbabwe.
Welcome. Welcome. Cleve, can you hear me okay? Can you just briefly introduce yourself, Cleve? I see you're in the hospital. Hello, Cleve. Can you please introduce yourself? He may not be able to hear me okay. Well, anyways, okay, Nathalie, thank you very much for the preparation, and it's all yours.
Okay.
Go ahead, Nathalie.
Okay, let me just.
Could you just say
Hello, everyone. I am Nathalie Ghumsi from Cameroon, a member of AFAN, Association of Future African Neurosurgeons.
Looks good.
Today is it okay? Is everyone's?
Yes, it looks good. It looks good.
Today I'm going to present on the anatomy of the thalamus. Our objectives will be to describe the gross structural anatomy of the thalamus, have a general idea on its functional anatomy, describe its vascularization, enumerate some thalamic lesions, and outline its surgical importance. So, in order to attain our objectives, we outlined firstly a brief introduction, the external and internal structure of the thalamus, its blood supply and some clinical significance. We will describe some thalamic lesions, some surgical approaches, and then finally we will conclude. The thalamus is part of the diencephalon, which is divided into 4 regions. We have the thalamus itself. Inferior to it, we have the hypothalamus. Posteriorly, we have the epithalamus, and inferiorly, we have the subthalamus. Etymologically, the thalamus is derived from a Greek word meaning an inner chamber. It's a paired and symmetrical structure found at the roof of the brainstem. Morphologically, both parts of the thalamus are each about the size of a walnut, in about 3 centimeters long, 2.5 centimeters wide, and 2 centimeters in height. The 2 halves of the thalamus are prominent bulb-shaped masses of about 5.7 centimeters, located obliquely and symmetrically on either sides of the third ventricle. As you can see on this second image. The thalamus is a large mass of gray matter which lies immediately lateral to the third ventricle. It is ovoid shaped, that has the shape of an egg, and it borders the dorsal part of the third ventricle. It is made up of 2 poles. We have the anterior and the posterior pole, and 4 surfaces. The anterior pole is just behind the interventricular foramina, and the posterior pole, made of the pulvinar, is just above the superior colliculus, above and lateral to the superior colliculus. Its superior surface is covered by a thin layer of white matter called the stratum zonale, which extends medially from the line of reflection of the ependyma, the tinea thalami, and forms the roof of the third ventricle. This curved surface is separated from the overlying body of the fornix by the choroid fissure with the tela choroidea within it. The tela choroidea is a fold of the ependyma and the pia mater. It is related laterally to the caudate nucleus and separated from it by the stria terminalis and the thalamus striate vein. The medial surface of the thalamus forms the superior part of the wall of the third ventricle. It is connected to the contralateral thalamus by the interthalamic adhesion behind the interventricular foramina. The hypothalamic circles forms the boundary between the hypothalamus that's up and the hypothalamus down and the thalamus upward. It curves from the upper end of the cerebral aqueduct and to the interventricular foramina. The thalamus is continuous anterior-inferiorly to the hypothalamus, inferiorly to the subthalamus, and posteriorly to the midbrain tegmentum. Its inferior surface, formed mostly by the ventral thalamus, separates the thalamus from the tegmentum of the midbrain. Its lateral surface is covered by a thin layer of myelinated fibers called the external medullary lamina, which separates the thalamus from the reticular nucleus. More lateral to the reticular nucleus is the posterior limb of the internal capsule. The internal structure of the thalamus is divided into three by a Y-shaped thin layer of white matter called the internal medullary lamina. The three groups of nuclei are called the anterior, which is with the orange color, the medial in blue, and the lateral nuclear group in pink. We also have additional groups of thalamic nuclei, such as the intralaminar thalamic nuclei and the reticular nucleus laterally. The anterior nuclear group is made up of three nuclei. We have the anteroventral, the anteromedial, and the anterodorsal nuclei. All these form the anterior thalamic tubercle, a major component of the limbic thalamus, which integrates into the purpose circuit of the limbic system. Functionally, they have a reciprocal connection with the hypothalamus, particularly the mammillary body, through the mammillothalamic tract, with the hippocampus formation in the temporal lobe of the via the fornix, cingulate gyrus, and the prefrontal cortex. Hence, they are involved in emotional aspects of behavior and memory. The discrete damage of the mammillothalamic tract has been associated with deficit in a specific type of memory, that is episodic long-term memory, with relative sparing of short-term memory and intellectual capacities. Secondly, the medial nuclear group is divided into the dorsomedial nucleus, which is the largest. We have the dorsomedial nucleus and other smaller nuclei, such as the nucleus reunions. The dorsomedial nucleus receives projections from the amygdala, the lateral hypothalamus, the temporal and orbitofrontal cortex, the spinothalamic and anterior trigeminothalamic tracts. It further projects to the prefrontal cortex and the cingulate gyrus. Hence, they are involved in mechanisms of pain. Though bilateral lesions of the dorsomedial nucleus result into a syndrome called the syndrome of loss of physical self-activation, which is manifested by anapathy, indifference, and poor motivation. The reciprocal connections between the prefrontal cortex and the dorsomedial nucleus can be interrupted surgically to relieve severe anxiety states and other psychiatric disorders. This operation, historically, prefrontal lobotomy and prefrontal locotomy were being done to relieve these psychiatric disorders. But nowadays, having been replaced largely by medical treatment that achieves, they have been replaced largely by medical treatment that achieves the same results without undesirable side effects. Thirdly, the lateral nuclear group, which is the largest nuclear group of the thalamus, is is divided into two parts. We have the ventral part, which is made up of 5 nuclei. We have the ventral anterior, the ventral lateral, the ventral posterior nuclei, and the lateral and medial geniculated bodies. While the dorsal part is made up of 3 nuclei. We have the lateral dorsal, the lateral posterior, and the pulvinar nuclei. The ventral anterior nucleus occupies the rostral part of the lateral nuclear group. It is divided into two parts. We have the parvocellular part, which is the largest, and the magnocellular part. They receive fibers from the internal globus pallidus and the pars reticulata of the substantia nigra. They send reciprocal projections to the premotor and the supplementary motor cortices. As for the ventral lateral nucleus, it lies caudal to the ventral anterior nucleus. It is divided into three parts. We have the pars oralis, the pars medialis, and the pars caudalis, also known as ventral intermediate nucleus. It receives projections just like the ventral arteriole from the internal globus pallidus and the pars reticulata of the substantia nigra. Additionally, it also receives projections from the dentate nucleus. Hence, it plays a role in the motor regulation. Hence, the use of deep brain stimulation of the ventral intermediate nuclei or thalamotomy to reduce cerebellar tremor or dyskinesia. The ventral posterior nucleus lies between the ventral lateral and the pulvinar of the pulvinar nucleus. It is made up of two parts. We have the ventral posterior medial nucleus and the ventral posterior lateral nucleus. They receive information from the spinothalamic and trigeminothalamic lemniscus, and also from the nucleus solitaris and the vestibular nucleus. It therefore plays a role in the mechanism of pain, the taste and the vestibular equilibrium. It then projects to the postcentral gyrus of the parietal bones, or the parietal lobe, sorry. The lateral geniculate body is found near the posterior pole of the thalamus, that's next to the pulvinar, ventral to the pulvinar. It is the site of termination. It is the site of termination of the optic tract. It receives axons from the ipsilateral temporal hemiretina and contralateral nasal hemiretina. It then projects via the reticular part of the internal capsule and the optic radiation to the visual cortex of the occipital lobe, that's next to the calcarean sulcus. A lesion of the lateral geniculate body, will lead to a homonymous hemianopia. As for the medial geniculate body, it is found next to the lateral geniculate body. It receives ascending fibers from the inferior colliculus of the midbrain via the inferior brachium and sends projections via the reticular part of the formation of the internal capsule and the auditory tract to the primary auditory cortex of the temporal lobe. Finally, talking about the dorsal group, which is made up of non-specific nuclei. We have the pulvinar as the largest of this dorsal group. The pulvinar has extensive connections with the association cortices of the parietal, temporal, and occipital lobes. It plays a role in selective visual attention, and speech mechanism. A stimulation of the pulvinar nucleus of the dominant hemisphere produces anemia, also called as nominal aphasia. The two other nuclei, that's the lateral dorsal and the lateral posterior nuclei, take part in the limbic thalamus system. It receives afferents from the hippocampus and sends efferents to the cingulate gyrus. The intralamina and reticular nuclear forms the other minor nuclear groups of the thalamus. The intralamina nuclei, as its name suggests, are enclosed within the internal medullary lamina in the caudal thalamus, while the reticular nuclei is a projection of the reticular formation it's a projection which is found more laterally. It's a projection of the reticular formation from the brainstem to the diencephalon. This reticular formation is found between the external medullary lamina, as said before, and the internal capsule. The intralamina nuclei is divided into two parts. We have the caudal part, which is made up of two nuclei, the centromedian and the parafascicular nuclei, and the rostral group, which is made up of three nuclei. We have the paracentral, the central, and the reticular formation. The dendrothalamic system of the cerebellum, the spinothalamic and trigenothalamic lemnisci, the globus pallidus and the cerebral cortex, and they send efferents to the striatum and other thalamic nuclei. Its main function is to maintain arousal and mechanism of pain, and take part in the mechanism of pain. Hence, a lesion of the intralaminar nuclei will lead to a reduced perception of pain and level of consciousness. Secondly, the reticular nuclei received, as we said earlier, it's a continuation of the reticular formation of the brainstem into the diencephalon. It is found between the external medullary lamina and the internal, the posterior limb of the internal capsule. It receives inputs from the cerebral cortex and other thalamic nuclei. The former are collaterals of the corticogenithalamic projections, and the latter are collaterals of thalamocortical projections. It projects to other thalamic nuclei. This table summarizes the different structures of the thalamus and their different functions. As we said earlier, the anterior group mainly takes part in the limbic system, and so its function is mainly seen in memory. While the lateral group, which is the largest group of nuclei, has many functions. We can find it in the extrapyramidal motor function, the primary motor function, and the sensation. Now, talking about the vascularization of the thalamus. The thalamus is being vascularized by four main arteries. We have the thalamus geniculate artery, which arises from the P2 portion. The thalamus geniculate artery, here is it. It arises from the P2 portion of the posterior cerebral artery. It will supply the ventrolateral part, the ventrolateral region of the thalamus. We then have the tuberothalamic We then have the tuberothalamic arteries. The tuberothalamic arteries, also known as polar arteries, which arises from the posterior communicating artery and supplies the anteromedial and anterolateral region of the thalamus. Thirdly, we have the thalamus subcortical arteries, also known as paramedian artery, which arises from the pre-communicant portion of the posterior cerebral artery. It mainly vascularizes the medial region of the thalamus. Finally, we have the posterior choroidal arteries, which arises from the P2 portion of the posterior communicant artery, supplying the posterior part of the region of the thalamus, including the pulvinar. We should know that in about one-third of the human population, the tuberothalamic artery is missing, and its territory is supplied by the thalamus subthalamic arteries from the same side. There exists an artery called the artery of the Chiron, which is an anatomic variant where a single unpaired artery arising from P1 portion of the PCA of the posterior cerebral artery supplies by the bilateral paramedian thalamic and sometimes the rostral midbrain. Bilateral paramedian thalamic infarctions is observed when this artery is occluded. Weakness, increased cranial pressure, increased intracranial pressure, motor deficit, seizures, ophthalmologic abnormalities, and in some cases, mental deterioration and personality changes are the main clinical signs and symptoms of thalamic lesions. Though the thalamus plays an important role in important functional role in movement, only 12% of patients have movement disorders such as tremor and dystonia. More commonly, 30% of patients present with present with epilepsy despite the tumor's deep-seated location. Another common finding in the thalamic lesion includes contralateral paralysis that affects one or both extremities. In addition, clinical presentation is correlated with location of the lesions with the location of the lesion, specifically lesions of the anterolateral thalamus, which are associated with sensation deficits and paralysis, while those of the posterior medial thalamus are associated with early hydrocephalus. The presentation can also include deficits in vision such as hemianopia, mitotic poor reactive pupil, and ipsilateral oculomotor palsy. This table tries to summarizes thalamic arterial supply, the thalamic arterial supply, and the principal features of focal infarction. For example, we will see that an occlusion or an infarct of the tuberothalamic artery will lead to fluctuating arousal and orientation, personality changes. That of the paramedian artery, or also called the thalamus-subthalamic artery, will lead to a decreased arousal just as the previous. But associated with that, we can have aphasia if it's on the left side and altered social skills and personality. An infarct of the inferior-lateral artery will lead to the post-lesion pain syndrome, also called as Dejerine-Roussy syndrome, hemiparesis, and hemiataxia. It also has auditive consequences since it vascularizes the medial geniculate nucleus. An infarct of the posterior choroidal artery will lead to a visual field loss, either by hemianopsia or quadrannopsia. We should also note that a lesion of this same artery can lead to variable sensory loss and weakness. Now we shall try to outline some thalamic lesions and try to describe their radiological images. We'll start by the vascular lesions. Infections are the first vascular lesions to which the thalamus is being subjected. The presence, these lesions are mostly lacunar, considering that all arteries supplying the thalamus are terminal arteries. We can see on this first image, we have an axial cut of an axial flare sequence showing the occlusion, showing a hypersignal, which is interesting the territory of the posterior choroidal artery. So we have an infarct of the posterior thalamus and the part of the occipital lobe. On this second image, this is an axial diffuse weighted image, which shows the infarct of the artery of Pécheron. As we said earlier, we said that an occlusion of the artery of Pécheron will lead to an infarct of both paramedian parts of the thalamus. So this is the infarct in white. Secondly, the thalamus can be subjected to hemorrhages. These hemorrhages are mostly due to hypertension. It can also be because by trauma, secondary to initial infarction or brain tumor. And because of its proximity to the third and the lateral ventricles, these lesions are often associated with intraventricular hemorrhage. On this axial CT scan, we can see a posterolateral hemorrhage, thalamic hemorrhage, with an lateral interventricular hemorrhage. On this gradient echo, axial gradient echo image, we can also see this young bleeding of the thalamus with an interventricular hemorrhage. Venous infections also, the thalamus could be also subjected to venous infections. Lesions could be also due to venous infections. For example, the infarction of the vein of Galen or straight cyanosis can lead to bilateral thalamic vasogenic edema. We have this vasogenic edema which appears as a hypersignal on this diffuse on this flare sequence. Sorry, on this axial flare sequence, we can have a diffuse edema. You can see the diffuse edema of both thalami. And on this T2 axial, on this coronal T2 sequence, we can see a diffuse edema of the thalami. This can be due to venous infarction of the vein of Galen. The thalamus can also be affected by calcification. These calcifications could be physiological or pathological. Physiological calcifications are usually asymptomatic and are detected incidentally by neuroimaging. This classification increases with age, but it is mostly found in basal ganglia than in the thalamus. While pathological classification could be due to various causes such as toxins, that is carbon monoxide, infectious disease such as HIV, cytomegalovirus, and toxoplasmosis, metabolic disorders such as a disorder in the calcium metabolism. It could be post-radic, post-chemotherapy. It can be inherited due to neonatal hypoxia or vascular malformation. On this axial cut, in this axial section of a CT scan, we can see an anterior calcification of the thalamus. Finally, we shall talk about some tumoral lesions. Glioblastoma represents the main tumoral lesion, the mostly found tumoral lesions of the thalamus. On imaging, like on this T2 sequence, we find we will have a hypersignal, a heterogeneous hypersignal around the thalamus with mass effect on the, we have a mass effect on the anterior horn of the lateral ventricle, on the anterior horn of the lateral ventricle. These lesions or these tumors usually have a heterogeneous enhancement on a T1 imaging, as you can see here. This is the same cut, coronal cut of this same image, where we can see a heterogeneous hypersignal. Gliomatosis cerebri could also affect the thalamus. Gliomatosis cerebri is a diffuse white matter infiltration. It appears as a hypersignal and T1 and flare sequence. So here we have an infiltration of the thalamus, the frontal lobe, the caudate nucleus, the lenticular nucleus, and part of the cingulate nucleus, of the cingulate gyrus, sorry. Lymphomas could also affect the thalamus. Lymphomas are mostly found in immunocompromised patients, such as HIV patients. In our context, most HIV patients with stage 4 have lymphomas. These lymphomas are seen as hypo-intense images on an unenhanced T1 cut, T1 sequence. They are seen as a hypersignal on a T2, on this T2 coronal sequence. This coronal T2 weighted image. We have the same imaging on the flare. It's still like a hypersignal on the flare sequence. And these lesions tend to have a homogeneous and contrast enhancement in absence of central necrosis, as you can see on the fourth and the fifth images. Now, we shall talk about the surgical approaches. The main objectives of the surgical approaches of the thalamus are functional diseases and tumors. As for functional diseases, deep brain stimulations of the ventral and intermediate nucleus are used to to solve dyskinesia, to regulate dyskinesia, tremors, and rest tremors and rigidity. I think we talked about it last time when we were talking about the basal ganglia, that deep brain stimulation could be used to regulate dyskinesia. So these are the different nuclei which could be stimulated to regulate dyskinesia, rigidity, or tremor, or dystonia. We have the ventral intermediate nucleus. As I said earlier, it is a part of the ventral lateral nucleus of the ventral part of the natural nuclear group. We have the globus pallidus interna and the subthalamic nucleus. We said it in the last, on our expose on the basal nuclei. As for tumoral lesions, the surgical approaches of tumoral lesions depends on the side of the, on the location of the tumor. For example, if we have the location and the location of the tumor is anterior inferior part of the thalamus, we shall use the orbitozygomatic transcavial, like here, this is the anterior inferior part of the thalamus. We shall use the orbitozygomatic transcavial supracarotid inferotemporal approach. We can use. If this tumor is located medially, we can use that medial. You can see it on this T2 image. We can use the anterior ipsilateral interhemispheric transcallosal approach to remove the tumor, or take a biopsy, or remove part of the tumor, as we discussed with Dr. Onoro. If the tumor is located, or the lesion is located laterally, we can use the anterior contralateral interhemispheric transcallosal approach. As we can see, we have on this T2 sequence, we have this tumor which is really massive. It is located laterally, mostly laterally. If the tumor is found posterior superiorly, so that's at the superior part of the thalamus, we can use the posterior interhemispheric transcallosal approach. As we can see, the mass is posterior superior, so this approach is best to remove this mass. If the mass is located, if the lesion is located at the lateral posterior inferior part of the thalamus, lateral posterior inferior part of the thalamus, we can use the parieto-occipital transventricular approach to remove the mass. And if the lesion is located medial to the at the medial posterior inferior part of the thalamus, is it? At the medial posterior inferior part of the thalamus, the subthalamic supracerebellar inferotemporal approach is the best. To conclude, I will say that the thalamus is a complex organ which is part of the diencephalon found at the center of the midbrain. It is divided into three nuclear groups. We have the anterior nuclear group, which takes part mainly in the limbic system. We have the medial nuclear group, which takes part in the mechanism of pain and behavior. We have also and lastly, the lateral group, which is the most heterogeneous group, which is sensory motor. It is being vascularized by four main arteries, which arises from the posterior communicant artery and the posterior communicant artery and the posterior cerebral artery. The main clinical syndromes are thalamic pains, hemiparesis, visual or auditory deficit, and dyskinesia. The main surgical value of the thalamus is for functional pathologies. I thank you for your attention.
Thank you. Dr. John, can I take over to introduce the newcomers?
Yes, please.
Thank you so much. So we are starting with our senior, Dr. Marco Meloni. Can you introduce yourself, please?
Hey guys, how are you?
Yes, senior. Can you introduce yourself, please?
Hi.
Yeah, hi, Marco. Could you please introduce yourself?
Okay. I could not see my picture in my video. Anyway,
Okay.
my name is Marco Meloni. I'm a consultant neurosurgeon in Gravedona, North Italy. Hello, everybody.
Welcome.
Hello.
Thank you so much. Dr. Mba, can you introduce yourself?
Hello. Yeah, I'm Dr. Mba, final year resident in Zimbabwe from Cameroon.
Thank you. Dr. Kabila, can you introduce yourself, please? Dr. Kabila, Dr. John, can you unmute Dr. Kabila, please?
Okay, I'm trying. Okay, go ahead. Go ahead. Go ahead. Go ahead,
Dr.
Doc.
Kabila, can you hear me? It's okay. We'll come back to you. Dr. Slachoyo, can you introduce yourself?
Hi, everybody. My name is Lawrence. I'm a resident student in neurosurgery, final year, together with Dr. Mba and Dr. Kabulo.
Welcome.
It's nice to meet you on this platform.
Thank you so much, Dr. Slachoyo. Dr. Kabila, can you hear me? If you can hear me, can you raise your hand up? Put your hand up. If you can hear me. It's okay, you can't hear me. Thank you, Dr. Bennett. If there's someone with questions to Dr. Nathalie, you can
How
ask.
about Dr. Samakande? He didn't introduce himself.
Dr. Samakande, can you introduce yourself, please? I forgot him.
Hello,
Dr.
everybody.
Samakande.
Okay, there we go.
Yes, hello, everybody. Yes, my name is Simbarashi Samakande. I'm a resident, final year neurosurgical resident at in Harare, Zimbabwe.
Welcome.
University of Zimbabwe.
Thank you so much. Dr. Kabila, can you hear me now? Can you introduce yourself, please?
Yes, I can hear you, Dr. Kabulo. Yes, I'm Dr. Kabila. I'm a general surgeon based in Zambia. Thank you.
Welcome. Welcome.
Thank you so much. Welcome.
Thank you.
It's okay, Dr. Bennett. You can carry on and ask if there's someone who with questions.
Okay, go ahead, Dr. Kabulo. Why don't you run the show? Go ahead. Take it over.
Yes. Is there any question for Dr. Nathalie? Dr. Nathalie, thank you so much. That was a very great presentation. Dr. Mba has a question for you. Carry on, Dr. Mba.
Hi, Dr. Nathalie.
Hi, Dr. Mba.
Yeah, this was a fantastic presentation. But I have two questions. The first one is on one of your slides when you were talking about calcification. I wasn't too sure whether that calcification, the slide you presented, was actually on the thalamus. I had the impression that it was on the head of the coded nucleus on the right side.
Okay, let me show the slide. There's it. Okay.
Right.
Okay.
Yeah, that one.
Yeah. Okay. Yeah. It's true that it's more anterior than I thought. Yeah. 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 I think it's the
Okay.
head of the nucleus, the coded nucleus.
Right. And about when you look at thalamic lesions, most of those lesions tend to affect one side of the thalamus, isn't it? Except maybe if you have massive infarct. What is the general presentation, clinical presentation of those patients? Because from what I know, patients with unilateral thalamic lesions tend to have what's called thalamic asthesia, where the level of weakness is disproportionate. Okay, they are unable to stand or sit, and they tend to fall on either backward or to the contralateral side.
We talked about it when we're talking about, depending on the nucleus which is being affected.
Mm-hmm.
There nucleus which plays a role in the movement. So we even signal it, like if you have a mass which is affecting the ventral lateral nucleus or the ventral past the motor nucleus, it can lead to a hemiparesis.
Okay. All right, thank you.
Any other questions? Anyone with a question to Dr. Nathalie?
Yeah. No, not really. Thank you.
It's okay. If there is no question, we'll move to the second part of this presentation. So thank you so much, Dr. Nathalie. That was a very great presentation. Yeah. Okay, Dr. Bennett, carry on.
Yeah, thank you very much, Dr. Gabullo, for running the show, and thank you all panelists. And I see Dr. Gabullo, Serge has quite a background there. So it can be done, Serge. It looks great. You see that?
Thank you.
Yes, Serge put the background, so villagers can also do it, but
yeah, we'll get it eventually. We'll get it.
Sure.
Thank you.
Okay, we'll wrap this up and we'll chat later. So thanks everyone for coming.